There we go.
Okay, so
Oh,
good
thanks,
evening.
Mary.
Good evening, everybody. So thank you to the Scleroderma Foundation Greater Lakes chapter, part of the Michigan group out here. And Dr. Ghosh and I'll talk a little bit about the excitement, the data, the safety, the efficacy, what we know about cellular therapies. So when we think about people with scleroderma, we are trying to prevent some of the complications that you see on the lower part of the slide. University of Michigan sees over 1,800 to 2,000 patients a year. There are four of us who are dedicated to this disease. We are about to hire a nurse practitioner, and the program has grown quite a bit since I took it over about 14 years ago. But one of the things that is always uh, really bothersome to me is the challenges of internal organ involvement, the impact that it has on the facial features, the contractures, but also the internal organ involvement. And when you think about systemic sclerosis or scleroderma, it's largely divided into two subsets. And this slide is important for patients to hear because the most common question that I will be asked, and Dr. Ghosh will be asked after this, is that why are we not candidates for stem cell transplantation? Systemic sclerosis or scleroderma is divided into diffuse cutaneous, which means a lot of skin involvement, but it's also associated early on within the first 5 years with heart, lung, kidney, gut, musculoskeletal Raynaud's phenomenon. And most of it when your skin is thickening, and many of you have gone through this, this is where you get lung fibrosis, GI involvement, hand contractures, and other aspects. Pulmonary arterial hypertension is a later complication, and that's why we do echocardiogram and lung function on an annual basis. When you think about people who have limited cutaneous scleroderma, many of you are called CREST syndrome. Again, the skin involvement is maybe minimal, but you do have risk of heart, lung, kidney, and pulmonary hypertension later on. And that is important when we are trying to target people with early systemic sclerosis. We just don't want to target the skin. We also want to help you with your lung fibrosis, gut fibrosis, and other kind of fibrosis such as heart and kidneys. So when you think about how we approach people with scleroderma, if you come to University of Michigan or go anywhere, we tend to target people who have Raynaud's phenomenon or digital ulcers with vasodilators, and they may be calcium channel blockers such as amlodipine, nifedipine, Adalat, Viagra, sildenafil, tadalafil. All these drugs are vasodilators. And what it means, it dilates your blood vessels so blood can go into your fingers, can go into your heart for pulmonary hypertension, can go into your kidneys. And then you have the fibrosis. On right are two of my patients who have lung fibrosis, scarring of the lung and the scarring of the skin. And for this, we tend to use immunosuppressive therapy, such as mycophenolate or Cellcept, methotrexate, cyclophosphamide. There are many, many immunosuppressive therapies. And then we have an FDA-approved drug called nintedanib or OFIF, which is an antifibrotic. And with Dr. Ghosh and her team, really what we have really pioneered and worked here at University of Michigan is stem cell transplantation, autologous stem cell transplantation, where we take stem cells out of your body, you know, try to take away the bad guys that cause the disease, give you quite a bit of toxic therapy, and then give your stem cells back to you. So when you come to University of Michigan or you go anywhere in the world at this time, most of us tend to use a drug called mycophenolate mofetil, which is also known as Cellcept. So over the last 15 years, we have followed approximately 300 people at 12 scleroderma centers in the United States. And they came to us very early on, disease duration of 1 year. So they had very early onset scleroderma and they came to us, and most of them, you can see 70% of the patients were treated with mycophenolate mofetil, and almost 90%, 86.4% were treated with some kind of an immunosuppressive therapy, whether methotrexate, whether cyclophosphamide. And one thing that I want to highlight to you is that in the short term, when you look at the clinical trial, these drugs seem to be effective. They seem to be doing much. But when you follow these people over a period of 5 to 10 years, you see that majority of the people who had worsening of skin tightening happened in the first 1 year. 360 days. So these are number of people achieving that. And you can see about 20 to 25% of the patients in the first year had clear evidence of skin fibrosis. However, what was concerning when I looked at this data is this worsening of lung function. You see people continue to worsen in their lung function, forced vital capacity, the breathing test that you do. And in fact, at the end of 5 to 7 years, approximately 40% of patients, despite being on mycophenolate and other immunosuppressive therapies, had progressive disease, and approximately 15% of the people died because of complications of scleroderma. This data is to highlight that we have therapies that are somewhat effective, but when you look at long term, is it really preventing, is it really putting into your remission? The answer is likely no. These therapies are not putting you in remission, but they may be controlling some of the symptoms that you have, but disease continues to have a slow but definite progression. This brings me to the work that I have done with Dr. Monalisa Ghosh, is what we call hematopoietic stem cell transplantation. And the thinking here is that you take away the dysfunctional immune cells that you have through certain conditioning regimen, and then you give your cells back to you after you have treated it. And you can think about resetting your thermostat at home. You reset your immune system and you restore to normal function. The study that we use quite a bit is the work that was led by Dr. Keith Sullivan and my mentor Daniel First, where they took people who had significant early scleroderma and randomized them with the flip of coin, either to get stem cell transplantation, very aggressive, they got stem cell mobilization, they got total body radiation. So your lungs and kidneys are covered and you get radiation. You got quite a bit of chemotherapy and other aspects, and your stem cells were given back to you. And at that time, we used to give IV chemotherapy called cyclophosphamide on monthly basis for 12 months. So that was the control arm. The patients who came into the trial, why it's relevant, because these are the kind of patients that we are looking for in the CAR T or cellular therapy. They were young, they had early disease within 2 years. All of them had lung fibrosis, and all of them had quite a bit of impact of lung fibrosis in their lung function, and they had a lot of skin involvement, what we call as diffuse scleroderma. And what we showed in this study was that transplant people going down is bad here. These are proportion of people surviving, and you can see at the end of 10 years or so,
Hi,
about
this is Debbie.
80%
Keith
of
just
the
stepped out
patients
to the
are.
store, but he was wondering how you were
Can you
feeling
put yourself
as
on
we
mute,
get
please?
going in the
Whoever
morning
is
to get his
talking in the
haircut.
background.
That's why he was calling you. I'm sorry?
You could see that 80% of the
I'm
patients who were
fine.
on
Just got a
transplant,
little setback today from my disease specialist that
80% of the patients who had transplant survived at 10 years compared to only 50% of the patients who were on chemotherapy, cyclophosphamide, and there were more people on cyclophosphamide who flared compared to who had autologous stem cell transplantation. This is rather remarkable data. We have had a lot of patients come to Michigan with Dr. Ghosh and I who have gone through this autologous stem cell transplantation and have done really, really well. Still, it is not a complete cure. You see, people do die because of this, but it's much lower, and people do flare, but it's much smaller than giving you chemotherapy. However, the big aspect of it is the toxicity. Giving somebody radiation to the whole body, giving you tons of chemotherapy. And if you look at the cyclophosphamide and transplant arm, and you look at the severe adverse events early on between the month 14, it is extremely high. And to be able to qualify for stem cell transplantation, you have to be relatively healthy. By what I mean is that you have early progressive scleroderma, but you have to have functioning heart. You have to have functioning kidneys because of the amount of toxicity and total body radiation that we are giving you. So that's one of the drawbacks because of the toxicity that is associated with autologous stem cell transplantation. There have been quite a bit of interest and excitement on the work that has been done in Germany by Dr. Josh Schett and Dr. Müller, where they started to use, and I'll have Dr. Monalisa Ghosh really go deep into the cellular therapy. They took the T cells from you, the person, and they engineered it to attack certain antigens, this case CD19 antigen, and we'll hear more about it. And they showed that it had a remarkable effect in people who had very severe lupus. And in this paper, patients also had scleroderma along with myositis and lupus. So here's a rationale for targeting CD19. CD19 is a marker of B cells. You have two kind of cells in your body, T as in Tom, B as in boy, and it's really targeting the T cells. Now, many of you have received rituximab, I suppose, and rituximab is a B cell therapy. So you may ask me, why are you not giving us rituximab? Rituximab works very well in depleting the B cells in your blood, but it does a rather poor job going into the skin tissue, going into the lungs. In fact, if you do biopsies on these patients, you still see B cells when you send it to pathology and you stain it. One of the big advantages of T cell is listed out here, its ability to go into the tissue such as lung, kidney, and other tissues where the B cells are residing with a high specificity and try to kill them. So that's a rationale behind using CD19 CAR T in people with autoimmune diseases, whether it's lupus, multiple sclerosis, myasthenia gravis. You can think about many, many autoimmune diseases. So I'll hand it to now to Dr. Monalisa Ghosh, and Dr. Ghosh, let me know, and I will happy to move the slides for you.
Thank you very much, Dr. Khanna. So I'm going to go back to some of the basics here. As Dr. Khanna mentioned, there has been a lot of interest recently in CAR T cell therapy as a really novel treatment in autoimmune disease. Now, we've been using CAR T cell therapy in the oncology setting for various blood cancers, such as lymphoma, leukemia, and multiple myeloma, for at least 10 years in clinical trials, and the first FDA approved CAR T cell product was available in 2017. So we've been treating people with the commercially available products since 2017. So at University of Michigan, we've treated about 250 people, all of them at this point who have had cancers with CAR T cell therapy. So CAR T cells, what they are, T cells, of course, are one of your types of immune cells that typically should be able to target and kill abnormal cells. But that doesn't always happen in those of us who have dysregulated immune systems or develop cancer. Our T cells are not working the way that they should in attacking abnormal cells. So the purpose of the CAR T cell is to actually go in and attack a particular, what we call an antigen or target on a particular type of cell. So CAR stands for chimeric antigen receptor. And what we do is we engineer your T cells so that a piece of DNA is usually put into the T cell, and that DNA provides the instructions for the T cell to produce on its surface the CAR, or chimeric antigen receptor, which is a protein structure. And once CAR T cells get into your blood after we infuse them through the vein, they divide and make more of themselves, and they can kill thousands of tumor cells. But in the case of autoimmune disease, thousands of B cells, which make the antibodies that attack your tissues and cause some of the effects of scleroderma. Next slide. This is just a little more detail on the structure of the chimeric antigen receptor. Basically, there have been multiple generations of CARs. The first one was developed in the late 80s, early 90s, the one on the left. And then the second generation and third generation structures are the ones that we have been using in the clinical setting for the past few years. And we're working to modify the different components of the CAR. We can engineer each of these different sections of this molecule to create the kind of CAR that we want, that we can engineer qualities into the CAR such as persistence, where these CARs can last for longer in the body. We've detected CAR T cells in people's blood 10 years after they get infused, so the CAR T cells can continue to work. And we also can engineer them so that they can expand rapidly or expand more slowly once they get into your body. Next slide. So as I mentioned, CAR T cell therapy was first studied in B cell leukemias and lymphomas. And the first simple CAR T, that first generation, was developed for in mouse models, actually, in 1993. The first FDA-approved drug was a drug called tisagenlecleucel, which was approved for acute lymphoblastic leukemia, which is a type of leukemia that affects both adults and children, but tends to affect children more than adults. So it was approved for people less than 25 years of age. Since 2017, we now have six FDA-approved CAR T-cell products, and they are FDA-approved to treat a variety of leukemias and lymphomas, as well as multiple myeloma. The common thread is that all of these CAR T-cell products target B cells. So that's why we have these products that treat these various B cell malignancies. And now we're studying in autoimmune diseases. Next slide. This is just a quick timeline of the different products that are out there. As I mentioned, 2017, the first CAR T-cell products were approved. We started using them in the clinic beyond the clinical trial setting around that time. And since then, we also have products for mantle cell lymphoma, another type of B cell cancer, follicular lymphoma, which is another type of B cell cancer. And then in the past couple of years, the FDA has approved 2 different CAR T products for multiple myeloma. Next slide. So how are CAR T cells made? CAR T cells right now, the ones that are on the market, and most of the ones that are being looked at in autoimmune diseases are autologous. So that means that they're your own T cells. So the way that the CAR T is manufactured, each product is an individualized product. It's your body, it's your T cells. We would not give it to anybody else. We would not make it for distribution. It would just be for you. So the process is first, your T cells have to be removed from your blood. T cells are floating around in the blood. So we do a process called apheresis, in which usually an IV is placed in one vein in one arm, an IV is placed in a vein in the other arm, or sometimes we place a catheter in one of the large veins in the neck, and we pull blood out from your body. Your blood goes into a machine. The machine then extracts the T cells from the blood and then returns the rest of your blood back in through the other IV. And this is a continuous process, a lot like dialysis. It takes about 4 to 6 hours, typically is done in the outpatient setting, so you don't have to be admitted to the hospital for this part. And then once we collect those cells and we get enough, we send it to the manufacturer, whether it's the pharmaceutical company, and some hospitals and clinics can locally manufacture these cells. But usually we send it to the pharmaceutical company that makes the drug product. And what they do is it takes them anywhere from 3 to 6 weeks to manufacture the CAR T cell. So it's not something that you're getting what we call off the shelf when it comes from your own body. There are some CAR T products that are being made out there. They're in the clinical trial setting that are from other people that are available almost immediately. However, those have different side effects, and I'll talk a little bit about those later. So what happens is they take your T cells and they put them in a bag along with, or a container along with little pieces of DNA. And this DNA is put onto a virus that's not active, because viruses are good at carrying that DNA into your cell. So the virus then acts as a vehicle, carries the genetic material, the DNA, into the cell, and then viruses insert the DNA into your cell's DNA. Then what it does is that piece of DNA acts as like a computer program or instructions, an instruction manual to the cell to produce that protein structure on its surface called the chimeric antigen receptor. And then the CAR T cells are allowed to grow and divide and make more of themselves. So they will return to us 4 or 5 times as many cells as we sent to them. So they'll usually send us back a bag, sometimes fresh, sometimes frozen, and that bag will contain billions to trillions of CAR T cells. And once those CAR T cells come back to us, we typically would treat you with a few days of chemotherapy, and I'll explain why in a minute, and then infuse the CAR T cells into you. Next slide. So this slide shows you the patient journey through the CAR T cell therapy process. First, we identify the appropriate patients. And right now, and even in the future, looking to when this might get FDA approved as a commercially available product that you could get anywhere where CAR T cells are administered, there are still going to be specific people who would be eligible for CAR T cell therapy. And it may depend on how many treatments you've gotten before, how many organs are involved, things like that. So first we identify the appropriate patients, and then you undergo leukapheresis, which is the collection of the cells from your blood. Then the manufacturing takes place over a few weeks. During that time, it depends whether or not you will need to do any additional treatment for your disease or stay on the same treatment you were on before. Sometimes a few medications that you may already be on have to be held prior to collection of the T cells, because different medications such as steroids or CellCept can actually affect the type of T cells we're collecting. So some people will have to hold their treatment for a few days prior to the collection of the T cells, but then may resume them while waiting for the T cells to be manufactured. And then right before the CAR T cells are administered, we would treat you with something called lymphodepletion. So that's the chemotherapy that I was talking about. We typically do anywhere from 2 to 3 days of chemotherapy, and you get a couple of different chemotherapy drugs. Usually this can be done in the outpatient setting. You don't have to be in the hospital. And as far as chemotherapy goes, at least compared to a lot of the chemotherapy regimens we use in the cancer setting, we consider this more lightweight chemo. But for people who have never received chemo before, it may be the first time that you're getting chemo and you experience some of the symptoms that come with chemo. So it's generally very well tolerated. Some people develop some nausea, but otherwise, most people tolerate it pretty well. So the purpose of this chemo is to prepare your immune system for the CAR T cells. The chemo actually helps to kill off some of the leftover T cells in your body, which could reject the CAR T cells once they come back into your body. So we're making room, we're making space for the CAR T cells. Then a couple of days after the chemotherapy, usually we give you 2 or 3 days of rest after the chemo. Then we infuse the CAR T cells. And right now, in the early days of using CAR T cells in clinical trials in autoimmune diseases, we will mostly treat people in the hospital. So you will get admitted to the inpatient unit and your cells will be infused there and you'll be monitored for a few days. However, in the cancer setting, we treat anywhere from about 20 to 30% of our patients in the clinic. So now people have to meet certain criteria, but that is likely going to be the future in autoimmune disease, is we may be able to do most of these treatments outpatient and save you the hospitalization. So the CAR T cell is infused usually through a catheter that's placed in one of your veins or an IV. And it typically takes anywhere from 10 to 15 minutes to infuse this liquid, just like any other IV medication. And most of the time, you're not going to experience any side effects within the first 24 to 48 hours, but sometime in the next 1 to 2 weeks, you may experience some specific side effects, which I'll talk about. Next slide. So CAR T cells, we know, are very efficacious in cancer. They've really revolutionized cancer therapy. And right now we are developing CAR T cells in what we call solid tumors as well: lung cancer, ovarian cancer. There are tens of thousands of trials out there developing new CAR T cells all the time. However, there can be lots of side effects. And so this slide just shows some of the specific side effects that we have seen and the ones that we see more of. The two that may have to just click again, Dinesh. There's a couple of, there we go. The two side effects that we see the most are one called cytokine release syndrome and another one which is neurologic side effects. So I'll go into a little more depth on those two because that's the most common. And then there are some other effects we may see. For instance, your B cells may never come back after getting this treatment. And B cells are actually important because they can help you, even though some of them produce those autoantibodies that cause a lot of the effects of different autoimmune diseases. They also produce antibodies that can help protect you against infection. So that can be a long-term side effect that we may see. And some people require infusions of antibodies or IVIG from other donors for potentially the rest of your life, but sometimes some people don't require any at all. So that's one potential side effect. The allergy to the CAR T, that's typically not an issue. I've actually never seen that or haven't seen that reported in any patient. So that's sort of a theoretical risk. There's something called insertional oncogenesis, which is where the DNA that is put into your T cells may slip into some other T cells in your body or other types of cells, or may turn some of your T cells into bad T cells that could become cancerous. So there have been a couple of reported cases where the thought is that this has happened, but that's out of thousands and thousands of people that have been treated. So it's not something we see often, but just something to keep in mind. Next slide. So cytokine release syndrome, this is the most common side effect that you may experience. Usually, if it happens, it'll happen about somewhere between 2 to 5 days after infusion of the CAR T cells. The most common symptom is fever. You may also get low blood pressure or low oxygen levels, but most of the time we just see fever in most of our cancer patients. And we anticipate actually that people with autoimmune diseases should not even have really should not have as severe symptoms as cancer patients do, because in cancer patients, a lot of the symptoms are due to the large tumors that they have. So the CAR T cells are killing these tumors and creating inflammation from that killing of the tumors. But you don't have tumors in autoimmune disease. You're killing a lot fewer cells, and do not expect to see a lot of inflammation driving these symptoms in people with autoimmune disease. So we do have treatments. We watch for this. If cytokine release syndrome is going to happen, typically happens in those first few days. And then once it resolves, it's gone and does not happen again. And some people, especially people with lots of cancer, lots of tumors, have gotten sick enough that they have to be in the intensive care unit for further treatment. But in general, it's something that's short lived and people survive this issue. And some of the treatments that we use include steroids, some cytokines like tocilizumab, which some of you may have used as treatment for your scleroderma. We actually use that to treat cytokine release syndrome. And then sometimes it just resolves on its own. Other issues, different organs can get involved, your heart, your kidneys, liver, some blood disorders. But again, we don't see that too commonly in people with cancer, but we usually see it in people who have more disease. So I don't anticipate we're going to see a lot of that in autoimmune disease. Next slide. As I mentioned, the mechanism of this cytokine release syndrome. So when the CAR T cells get into your body, in people with cancers, they bind to the T cell. And the CAR T cells that are on the market right now for cancers target CD19, which is another protein structure that's on the surface of the B cells, the cancer cells. And in autoimmune disease, we're targeting the same target. We're targeting CD19 with some of these CAR T cell products. And CD19 is on the B cells that are likely producing those autoantibodies. So we're trying to kill off those cells so that they don't produce the autoantibodies. And what happens is when the CAR T cells bind to those B cells and start killing them, they physically kill those B cells. They insert enzymes and trigger different pathways within the B cell to kill them. And then that causes local inflammation. All these other immune cells from your immune system come and join the party. These cells that release these tiny factors called cytokines, which are what cause the inflammation. So we anticipate this to be very low grade in autoimmune disease, because in cancer, we have observed that people who have more tumor, meaning if somebody has large 10-centimeter tumors or tumors all over their body, they tend to get more severe cytokine release syndrome, whereas people who have maybe one small tumor don't get such severe cytokine release syndrome. Next slide. And as I mentioned, the treatments include steroids, which reduce the inflammation, and anti-IL-6 therapy. So IL-6 is one of those cytokines that causes the inflammation. And so we luckily do have a couple of different antibodies that fight against IL-6. So we use those. Now, with steroids, we try to avoid using them if we can. And this was sort of the dogma when we first started doing CAR T cell therapy, was that steroids could hurt the CAR T cells, so we don't want to use too much steroid. However, we actually have had recent studies that came out that showed that steroids may actually even help the CAR T cells to some extent. We still like to avoid high doses of steroids, and especially in scleroderma, we know that high doses of steroids can cause some other organ issues. So, really, the only time we would need to use high doses would be if you had severe cytokine release syndrome, but we have alternative therapies to steroids. Next slide. Now, another side effect is what we call neurologic toxicity, but also known as ICANS, or immune effector cell associated neurologic syndrome. So, this is a type of disorder that we have seen in different settings. It can happen at the same time as cytokine release syndrome, or it can happen even after the cytokine release syndrome has resolved. And sometimes we've observed it in people who did not even have cytokine release syndrome. Usually, if it's going to happen, it'll happen in the first 7 to 10 days after CAR T cell infusion. Most of the time, it lasts for 4 to 5 days if it does happen, and usually happens about 4 to 5 days after CAR T cell infusion. So, what we can see is people can develop headaches, they may have some tremors. You could have short term memory issues where you forget the date or forget where you are, may have some difficulty expressing your thoughts, some confusion, and in very severe cases, seizures. But I've never actually seen that happen in any of the 200 plus patients I've treated with CAR T cell therapy. We anticipate this will be very, very rare in autoimmune disease. And that's because, again, in people who have cancers, a lot of them have cancer that is in the brain. A lot of them have cancer cells that are penetrating the brain tissue and the fluid around the brain. So we think that the degree of these symptoms are related to that in cancer patients, as well as the severe degree of inflammation that happens in cancer patients. So again, we don't really anticipate seeing much of this in autoimmune disease. We do, this is just showing a little bit more of the mechanism of how the neurologic side effects happen. We think that what happens is what you have is the blood-brain barrier. That's just the vessels that protect your brain from what's going on in the rest of the body. But when you get CAR T cell therapy, if you have a lot of inflammation in your body, that actually breaks down that blood-brain barrier and creates holes in it so that the CAR T cells can get into the brain and cause inflammation within the brain. But again, we don't really anticipate seeing that much inflammation in autoimmune disease. So we may not see this as much in autoimmune disease. In the trials, the case reports that have been presented so far, they've seen very mild, if any, neurologic side effects, and most people did not have any of these neurologic side effects. The treatment we use is steroids for this. Okay, next slide. There are some additional risks, as I mentioned, the prolonged depletion of your B cells. So, we do actually think that it's possible that some of the B cells will come back, even though CAR T cells can hang around your body for years and years. They actually can divide and make more of themselves. And that's one of the benefits of CAR T cells versus something like rituximab, which, yes, it kills the B cells, but it's more transient. So you have to get multiple doses of rituximab. Right now, we just dose CAR T cells once, at least in cancer patients, and sometimes a couple of times. But in the future, we'll see how it goes with autoimmune disease, but we anticipate it may just be a one-time dose versus maybe once every 5, 6 years, something like that. Because the CAR T cells also create what are called memory cells in your immune system, and those cells can also go out and keep continuing to attack B cells. What we have seen in people with B cell cancers is that, yeah, amongst those people, about 50% of people, their B cells do start to come back to some extent, but that doesn't mean that they're going to relapse. So we do see that in some people, and that can protect them against infection. However, if you do continue to have your B cells depleted, then that also reduces your ability to produce certain antibodies, which may put you at just a slightly higher infection risk of the upper respiratory infections, things like that. There also, some of you may have seen in the news that there have been some reports that there may be some cancers that are related to CAR T cell therapy. And so what happened is the FDA received a total of 19 cases of reports of T cell malignancies, cancers, reported by 2023. So about 40,000 people worldwide now have been treated with CAR T cells, all for cancer for the most part. And these cases are still being reviewed by the FDA. From the data that I've seen, out of all these cases, we're not sure if any of them are directly related to CAR T cells. There are lots of different causes of cancer. There has been one report of the CAR, that genetic material I talked about, the DNA that was found in the cancer cell, but that can happen. It's not necessarily the CAR T cell itself that induced the cancer. So we don't really have clear evidence. It's a very small number of cases. And also, people who have one type of cancer are at higher risk of having another type of cancer, unfortunately. So there are some risks that are associated with it, but we think it's very, very minimal at this time, and the benefits clearly outweigh the risks. Next slide. So this slide just sort of shows, this is a really nice slide from Dr. Schett, who did the studies in Germany of the autoimmune patients. So you have your autoimmune B cells. So this is if somebody is preparing to go to CAR T cell therapy. They're stopping some of their other autoimmune drugs that they're on in preparation for getting the CAR T cell therapy. You get your cells collected, and then you're waiting for the cells to be manufactured. Then you get lymphodepletion, that chemotherapy I talked about, followed by the CAR T cell infusion. At this point, you have the disease that's active. But then once the CAR T cells get into you, as you can see by that black line there, the thick black line, the T cells expand very rapidly. So they get into the body and they expand, and they make a bunch of themselves in those first couple of weeks after CAR T cell infusion, which is why we see all the side effects really happen in those first week or two after infusion of the CAR T cells. And that's where you get the most killing of the target cell, which is the B cells. So the B cells in the blood as well as in the tissues are getting killed by the CAR T cells. Then a lot of those CAR T cells themselves start to die off, but a few of them are left over and keep propagating for a long time. And what they observed in a lot of their patients is that a lot of the patients started recovering their B cells. And when these B cells started coming out, they were what are called naive B cells. So these are naive B cells that aren't going to necessarily be producing the autoantibodies that the original B cells that were causing the issues would produce. However, over time, there is a possibility that you could have recurrence of the autoimmune disease. But at this time, what we're seeing is a drug-free remission in a lot of patients for a significant period of time. Of course, this data is very early, and we still need to see longer-term follow-up, but this is basically the pattern that we expect to happen in autoimmune disease. So there are other types of cell therapies that are being looked at in autoimmune disease. CAR T cell therapy is just one type of immune cell therapy. There are also other CAR T cells that target different, what we call the antigens. So the ones that are in most of the trials right now, and the ones that we use in cancer for the most part, target CD19, which is on B cells. But there's also CD20, there's CD22, and there's something called BCMA, which is what we target for people with multiple myeloma. That's present on cells called plasma cells, which are also responsible for producing a lot of autoantibodies. There's also what we call allogeneic CAR T cells, which I alluded to earlier, are T cells that we extract from a healthy donor and then produce multiple products that can be available immediately without having to wait for that manufacturing time when you're extracting T cells from individual patients. There's also a type of cell out there called NK, or natural killer cell. And this is a cell that can kill cancer cells. It can kill all kinds of abnormal cells in the body. That's its natural function. And so if you add a chimeric antigen receptor onto an NK cell, what we've seen in the cancer setting is these type of CAR NK cells actually don't produce the side effects that we see with CAR T cells. So they don't produce the cytokine release syndrome or neurologic side effects. And these CAR NK cells are also what we call third-party cells. They are typically extracted from a healthy donor and can be immediately available. So that's something that's being looked at in trials as well. We are looking to start some trials with CAR NK cells at University of Michigan. There are Treg cell-based. So Tregs are T regulatory cells. They're very important in autoimmune disease. and you can add CARs to these regulatory cells. They also most likely would have lower rate of side effects than CAR T cells, so that's being looked at as well. So I think at the time that we made this slide, Dinesh, there were 17 ongoing open studies, but now there's a lot more. So there are a lot, everybody is very interested in developing trials. And so there are a lot of CAR T trials, NK CAR trials, et cetera, that are being developed. So we have a few trials. We have 2 trials for CAR T open for scleroderma at University of Michigan, and we're going to open another one in a few months. And then, as I mentioned, we have some NK CAR trials in development. So, in summary, some of the potential benefits of CAR T cell therapy over some of the other treatments that are used. We think that this could provide a prolonged drug-free remission in several patients and many patients. You can get deeper and prolonged depletion of the B cells than you could with treatments like rituximab. Um, you can get quicker access if we are successful in treating people with these products that come from a third party. So that would be quicker cells. However, some of those may have to be infused multiple times because the body does get rid of other donor cells quicker than your own cells. And we think that there are fewer side effects than a treatment such as stem cell transplant. Those of you who may have undergone a stem cell transplant, it can be very, very hard. It's a really tough process, and it can affect lots of organs and cause a lot of different side effects, and can be a very tough process to get through. We anticipate CAR T cell therapy is going to be a lot easier to get through, and that we can treat more people with CAR T cell than we can with stem cell transplant, because in stem cell transplant, you actually have to have fairly well functioning organs otherwise in order to be eligible for stem cell transplant, whereas we can maybe treat people whose organs are not looking as good with the CAR T cell therapy.
Thank you, Dr. Ghosh. This is really helpful every time I listen to you. So I will maybe spend, 5 more minutes going over some of the data, because as people with scleroderma, you might be interested. So the question always comes, why B cells? And Dr. Ghosh alluded to that. I alluded to it. I think there are 3 trials that have been done in Japan, in India, and in London, UK, that showed that rituximab does something. Rituximab is not a cure, but it's clear that rituximab, it targets the B cells, seem to be somewhat effective for shorter duration. So that's one of the ideas. And really, if you had to really think about it, the deeper depletion you do, the more active you are in depleting those bad guys, the bad B cells, the cells that are making autoantibodies and activating your T cells, the better you likely will do. And the way to think about it, this is what rituximab does. This is the depletion, and this is what the CD19 CAR T does. It's a superficial B cell depletion with the rituximab antibody, and you're resetting the immune system, versus here the autoreactive, or the bad guys are still persisting, although you have transiently decreased their number, but they tend to recover back quite quickly. So here's the data from Dr. Shet, and I want to remind you, most of the data comes from one center. So as scientists, we want to replicate data in multiple people, multiple ethnicity, multiple diseases. So you have to be a bit aware of the data. Now, most of the data that comes is in lupus, because lupus nephritis, lupus is truly a B cell driven disease, and that's what they started to target. So this is the data from Dr. Müller from Germany, but there are other people, but largely in Europe and China, who has contributed to the data. 29 people with lupus, 13 with lupus kidney disease. There have been 5 patients with myositis and 4 patients just in Germany that have been treated with scleroderma. One thing that is very clear is that people have done remarkably well. People with lupus have gone into remission. Their kidney nephritis or inflammation has dramatically improved. People with myositis have improvement in their function, muscle strength, and in scleroderma, quite a bit improvement in the skin thickening and improvement in the lung function. The other thing that Dr. Ghosh talked about was CRS, cytokine release syndrome, and like she highlighted, all of them have been very mild, transient, lasting a day or less, and have been reversible. And there has been one patient with ICANS, which was dizziness. And sometimes you are unable to differentiate because the patient is lying in the bed and they stand up and they get dizzy for 10, 15 minutes. And, it's usually we err towards being conservative and we might call it ICANS, but there was one patient that was reported to have reversible ICANS, which is a neurological disease. Uh, Again, what you want your B cells, the memory cells, the cells that are keeping a memory of what to do from an autoantibody production to attack your system, the cells that are coming back after you are treated are naive B cells, and that's what you want after CAR T. So she talked about the CAR T being an explosion, and they immediately go down within 20 days, and the B cell depletion happens quite profoundly and immediately, and then your B cells start to come back approximately 100 days on average. And what you're seeing are the good cells, naive cells that are new, healthy, don't have the memory for scleroderma and others come back, and you see the memory cells that had kept the memory of it dramatically go down, and in most cases completely disappear. Autoantibodies, some of you have scleroderma specific antibodies. So lupus patients lost their autoantibodies, majority of them except for one patient. You can see very high double-stranded DNA associated with lupus kidney disease. Single-stranded DNA, myositis antibodies, but to highlight that majority of the people tend to lose antibodies, although not everybody loses their scleroderma and other specific antibodies. And finally, I think one of the concerns of targeting your B cells is what is going to happen to the good part of my immune system. Remember, as a child, you got polio vaccine, you got MMR and others. And one thing that is quite gratifying when you look at the data is that most of the vaccination, whether it's against measles, mumps, rubella, COVID-19, pneumococcal tetanus, stays stable. So it seems like that the CD19 are not the part of the immune system that keeps the memory of the good part, which is your immune system. So unlike stem cell transplantation, you don't have to go back and get all the childhood vaccinations again, because stem cell transplantation really targets all your immune system, not just the bad guy. And then here are the 4 people with scleroderma. And just to highlight, there was quite a bit of improvement that happened in these patients. And here are the 4 patients from Dr. Shed data. 3 patients had mild fever, that's a CRS grade 1. And I don't think anybody had tocilizumab. They just got Tylenol and other treatments that you will give for very mild fever. And there have been no ICANS that has been reported in scleroderma patient population so far. And the side effects are important. And here are all the 15 patients by Dr. Shed. And you can see most of the side effects: UTI, urinary tract infection, a lot of COVID-19, because when they were doing a lot of COVID-19 attacks, herpes zoster, herpes, shingles, zoster is shingles, and then there have been another shingles out here. So again, part of the immune system, the good guys that are keeping an eye do tend to go down, and seem to me that there are 3 different cases of herpes that has happened in this patient population. Now, you always want to replicate the data. As scientists, we want other experts to do that. This is another group that published in Germany, a different group. And here's a patient that will relate to a lot of you. This patient had lung fibrosis, and this patient was on chemotherapy, mycophenolate, and OFEV. They tried everything, and you can see that their skin score was worsening. You can see the skin score going up out here, and their lung function was going down. So this is bad when it comes to lungs, and this is bad when it comes to skin. And you can see the fibrosis as seen in red and the markings out here. This is a CT from 7/22, July of 2022. They underwent CAR T, and like Dr. Ghosh talked about, you see, CAR T expansion, and then they go away, and the scleroderma 70 antibody in their body, completely almost went away. But one thing that you want to see clinically, and that's how we are defining the trial, what happened to the CT a year later. Red is bad, green is good, and you can see complete or almost complete resolution of lung fibrosis. Now that's a very powerful data, just to show, a picture is worth 1,000 words, and you can see clearly the beautiful improvement that you see. The green part here are the fibroblasts, your myofibroblasts, the bad fibroblast collagen, and you see quite dramatic improvement in the degree of collagen and fibrosis in this patient population. So I really like this data because this is replicating data from another group on another patient population. So who are the people who are we considering right now as we talk 2024 and the next few years? We are targeting people who are early in their disease. That's where inflammation is. That's where the inflammation and immune activation is targeting your fibrosis or causing the fibrosis. And this is similar to the photograph I showed today earlier in the day. When the skin is thickening, you're getting most of the internal organ involvement. And when you think about a disease in a different way, early on, you have a lot of activity. Activity by definition is things that you can reverse, and damage are things that you cannot reverse. Once they happen, they happen. There's nothing really right now from a medication standpoint that I can do to reverse it. For 7 to 10 years is the period we are extending. When we wrote the initial protocols, it was 7 years. Now we are pushing it to up to 10 years. So here's a CT, a CAT scan of a patient with lung fibrosis. There's a lot of activity. There's a lot of inflammation you see out here and here, whereas here there's quite a bit of damage. The lung is completely damaged. There are holes, what we call honeycombing in the lung. So there's no way to repair the holes when they happen in your lungs. That is not what we can do in 2024 or any near future. And then here are people who we are targeting, people who have early diffuse scleroderma with early hand contractures or large joint contractures. And here's a person of mine who has quite a bit of damage, where the damage has been done with the claw hand deformity and the calcinosis and things like that. So it is a toxic therapy. I mean, we heard quite a bit of side effects. So we want to make sure that the disease you have is largely reversible and not something that is profound damage that we cannot reverse. So we want active disease, we want reversible disease, and we want disease with predictably poor prognosis. So most of the patients we are including, we are increasing this age limit to 75. We are trying to push it to 10 years. But you must fail one of the traditional immunosuppressive therapies, whether it's tocilizumab, Cytoxan, mycophenolate, methotrexate, Plaquenil. And there are two large cohorts that we have defined. One is with extensive skin involvement early on, and the other one diffuse or limited scleroderma with internal organ involvement, including lung fibrosis. So I will stop there, and I think we should open it for question and answers. And if you're interested, like Dr. Ghosh said, we have ongoing 2 CAR-T trials. We are about to launch another one with Novartis. And then there are 1 or 2 NK CAR, which are off-the-shelf treatments that will be starting later this year at University of Michigan for people with scleroderma and other autoimmune diseases. So Peggy, I'll give this back to you. I will leave this slide here if people are interested. And then we can answer questions if people have for us.
Okay. Who has the first question this evening? Nobody has any questions? There we go. Shuba.
Hi, Peggy. Hi,
Hi.
doctor. My name is Shubha, and I'm a newly diagnosed patient. I got diagnosed last month. And since University of Michigan, my primary care physician sent the referral to the University of Michigan for rheumatology, but for some reason they declined my case. I was not told what was the reason, but then they asked me to go to someone else, and I went to IHA, Trinity Health. So, and I'm already seeing a doctor now. Mine is a limited version of that. So I was just wondering, what do I expect from this disease? I have no clue. I'm a healthy person. I was a healthy person, I would say. Before the diagnosis, I don't have any I don't take any prescription medication or anything of that sort. I eat healthy, sleep well, do a lot of exercise, and have a good lifestyle. So I'm not sure why I got this. It got I saw those first symptoms a few years back, like 4 years back or so, and I went to my primary care physician. She said it's Raynaud's, and then I went again next year. It was in 2019 or 2020, maybe, I don't know, just around COVID. She said, well, if it flares up, then we'll do something like calcium channel blockers. But last year I started feeling a lot of dry mouth condition, and that's when I went to my doctor this year in April, and then she diagnosed me. I have a lot of good. So she died last month, or maybe in the month of May. I wasn't feeling well, so I went to the emergency room. They diagnosed me with GERD, and they gave me the Pepcid, and that have been taking. Other than that, I have dry mouth. I do feel some fatigue, some joint pain. I do regular exercises, but then I increase my exercise thinking that it might make me feel better. And it did. I don't have any more pain, or barely any pain. I don't take any pain medication. I was just wondering, what do I expect from this disease? 2 years down the line, 3 years down the line, how is it going to progress? I heard it's a progressive disease, but
ma'am, that's a lot to unpack. I don't want to overwhelm the doctor, so maybe we can just let Dr. Khanna address some of the basics and go from there.
Yeah, I think that's where the National Scleroderma Foundation plays a very important role. So I would strongly suggest to you to read some of the material on the National Scleroderma Foundation. They do a really good job, and there are lectures that are highlighted, what to expect. But the key part with early limited scleroderma is internal organ involvement. And everybody starts with limited scleroderma by definition, and some people develop diffuse subset over a period of 1 to 2 years. So you should be getting the lung function, the CT of the chest, the echocardiograms, even if you're feeling fine. That doesn't rule out lung fibrosis. So that's the way that I would start. And if you indeed have internal organ involvement, you should be treated because the disease does not go away by itself. It's an autoimmune disease.
Okay. Thank you.
Sure, absolutely. Any other questions?
There's one in the chat, Dr. Khanna, and I can't get my chat to open up. Randy, can yours open?
Yeah, I'm looking now.
I just said thank you for very informative presentation.
Oh, okay.
Yeah.
So
and we have, can you imagine a future in which CAR T therapy could be used for patients with long-term limited sclerosis, or will it always only be helpful with diffused, fast progressing disease?
Yeah, I skipped this slide. Maybe I should not have skipped this slide. So, what we talked about is that you have genetically modified your T cells out here to really target the CD19. Now, there are certain diseases such as myasthenia gravis and other that we know what the antigen is. That's a single antigen that's causing the disease. And you can have those T cells target those single antigen. You don't have to target the whole B cells because, like Dr. Ghosh and I talked about, B cells have important functions. So when you're targeting bad B cells, you're also killing the good cells, CD19 B cells. To answer your question, there might come a time where we are able to have CD19 against the fibroblast. So most of the people who have damage due to diffuse or limited scleroderma or long-standing lung fibrosis, you may be able to develop T cells that are targeting the fibroblast activating protein. And that is a long-standing damaged fibrosis. And you can start to do that to reverse some of it. So I'm sure there will come a time, but I think what we are trying to do, we are very, very early in the stage of developing these in autoimmune diseases. And we want to see whether people who have early progressive diffuse or limited scleroderma with lung fibrosis has this remarkable improvement and they're able to tolerate it. If that, I'm sure the field will go towards people who have more established systemic sclerosis or scleroderma.
Okay, next question that we have is, a thank you for the presentation to both of you. And is there any risk that CAR T cell therapy could cause a flare-up or worsening of the scleroderma symptoms?
So the flare of scleroderma symptoms should not happen because you're targeting the abnormal B cells that we believe are important. However, the CAR T, when you do CAR T, as we heard today, there can be a cytokine release syndrome. There could be CNS, central nervous system side effects. So if you have a significant lung fibrosis, that's why Dr. Ghosh highlighted this inclusion and exclusion criteria. If you have significant lung fibrosis and the CAR T, the T cells attack your B cells, interact with the B cells in the lung, you can get an acute flare of your lung fibrosis. And that's why we try to take people who have a decent amount of lung function and not very severe lung function. It is not a flare per se of your scleroderma, it's just a reaction, expected reaction to the CAR cells that are being targeted. There can be disease that will come back. I'm not promising, we are not promising anybody that this is long-term remission. But we believe that if this is effective, you might be in remission for years, months, 2 years to come, and you may need another treatment, but time will tell. We don't know that.
Okay. And then is there any data in MCT disease?
Yeah, mixed connective tissue disease, Miss Divine is asking, Anita Divine is asking that. Yes and no. I mean, people haven't looked at mixed connective tissue disease, but we have looked at lupus, scleroderma, and myositis, and people who don't know about MCTD, it is a combination of those diseases. So in early MCTD with lung fibrosis, CAR T should be effective like it's being effective in lupus, scleroderma, and other diseases.
Okay. Is it possible that patients might require additional CAR T therapy if the initial therapy does not result in significant improvement?
Monalisa, do you want to take that?
Sure. I think that that is a possibility. And however, if you don't see improvement with it the first time, we may not go back to using the same CAR T, but you could perhaps get a different CAR T. And when I say different CAR T, I mean that a CAR T cell that's targeting a different antigen. So maybe not targeting CD19, maybe targeting BCMA, which is on plasma cells that also produce antibodies. And also, sometimes in a situation where someone goes into remission for 3 or 4 years, but then the disease comes back, maybe that's the kind of person that you would try treating again because they got a significant few years of remission. We've done that in the cancer setting. In the cancer setting, people's tumors can grow back without CD19. And then in that case, doing a CD19 targeted CAR T again doesn't help because the target is not there. So in this situation, you may end up having relapse with the target still there, so you could use CAR T again potentially.
Okay. Are there any effects of CAR T on cardiac and renal fibrosis?
I mean, Dr. Ghosh and I can take that, try to answer. There should be beneficial effect, right? If the inflammation is causing the fibrosis, and in fact, in early scleroderma with cardiac involvement, active inflammatory cardiac involvement, those people are being considered for CAR T. And the same should happen with renal fibrosis. But Anita, if you're asking long-standing renal crisis, we don't know yet. We don't know yet. I think the risk likely outweigh the benefits at this time, because CAR T is a method. It depends what you are targeting. That is the most important part. And what is that T cell targeting? Right now we are targeting the B cells, but in fibrosis, long-standing fibrosis, that may not be the culprit anymore. It was a culprit early on, but it's not the culprit anymore. We need to get a little bit more guidance, information, basic science done in this area so we can really effectively treat you without causing all the toxicity that goes with it.
Okay. Anyone else have any questions? Okay, we've had a couple people in between the questions you've answered, thanking you for a great presentation, and just, being here tonight. So we want to extend that thank you to you. One last call for any questions? Okay, doesn't look like anybody's typing. Oh, we got a hand up. Yen Chen.
No, I just clapping. Thanks so
clapping.
much, Dr.
I heard you
Okay.
clapping, Yen. I heard you clapping all the way here in Michigan. So
Okay, everybody. Well, thank you very much. And if there are people who are more interested, Peggy, if you want to post it on the Michigan website, we can ask also, the chapter, the national chapter, to do that. There's a lot of interest. There are a lot of questions, and I hope that Dr. Ghosh and I've been able to answer some of them for you. Thank you.
Perfect. Thank you very
thank
much.
you. Thank you
Thank
both.
you.
Bye.
Bye.
Thank you,
Thank
everybody,
you.
for coming, and have a great evening.
You too. Yeah, we're so great. I'm eating.